Hello, my name is Frances Mills, and I am the director of the Cleveland Office of Minority Health. Throughout the month of April, the Cleveland Office of Minority Health, in partnership with the Gathering Place and Taussig Cancer Center, will bring to you a series of programs to provide health education and resources on the impact of cancer in the African American, Hispanic, and LGBT communities. Minority Health Month was established in 1989 as a 30-day high-visibility health promotion campaign. In 2000, Minority Health Month became a national celebration. Minority Health Month is designed to bring to you critical information for disease prevention. It is designed to provide tips and resources for healthy living. It is designed to provide information to you about the disparities amongst communities of color in the state of Ohio. But most of all, it is designed to build support and to gain resources to improve minority health throughout the year.
Good evening, everyone. I apologize. Michelle Serranian, our CEO, had a family emergency and was unable to attend this evening. But I would like to welcome all of you on the call this evening to tonight's program, Prostate Cancer in the African American Community, Part 1. This is going to be the first. Sorry, if folks could mute their just. Thanks, everyone. Anyhow, tonight's program is the first in a series titled Prostate Cancer in the African American Community, Part 1, which is proudly co-sponsored by the Cleveland Office of Minority Health and the Taussig Cancer Center. If this is your first time for joining us, we welcome you. The Gathering Place is a cancer support center here in Northeast Ohio, offering free programs and services to individuals and families coping with cancer. Over 20 years ago, we opened our doors, and since then, we have served over 47,000 participants. Throughout the Minority Health series, our goal is to provide health education and resources to help impact change. Studies show minority populations are disproportionately vulnerable to premature death and high incidence of chronic illness. During tonight's program, we will unpack the basics of prostate cancer, discuss the importance of screenings, and open for discussion. That said, it is my pleasure to introduce our speakers for this evening. First, you'll hear from kidney transplant surgeon and urologist, Dr. Charles Modlin. Dr. Modlin is a noted national leader for the Eliminating Health Disparities. Honors include appointment to the Ohio Commission on Minority Health Community Service Awards Honors include appointment to the Ohio Commission on Minority Health by 2 Ohio governors, Northwestern University Presidential Alumni Medal, Dr. Martin Luther King Jr. Community Service Award recipient, among many other recognitions and awards. In March 2020, Governor Mike DeWine appointed Dr. Modlin to serve on the Minority Health Strike Force, where he chaired the Education, Communication, and Outreach Subcommittee. The strike force formulated a number of recommendations to help address the disproportionate incidence and death rate.
Hey, Beth, you muted yourself by accident.
Sorry, folks. Can we start over?
Nope, you're fine. Just after introducing introducing who Dr. Modlin is, just starting from there.
That's awesome. Okay. Anyhow, oh, that's so funny. I apologize. Anyhow, let me introduce Dr. Modlin. He's our first speaker. He's a kidney transplant surgeon and urologist. Dr. Charles Modlin is a noted national leader for eliminating health disparities. His honors include appointment to the Ohio Commission on Minority Health by 2 Ohio governors, Northwestern University Presidential Alumni Medal, Dr. Martin Luther King Jr. Community Service Award recipient, among many other recognitions and awards. In March 2020, Governor Mike DeWine appointed Dr. Modlin to serve on the Minority Health Strike Force, where he chaired the Education, Communication, and Outreach Subcommittee. The strike force formulated a number of recommendations to help address the disproportionate incidence and death rates from COVID-19 in communities of color. Following Dr. Modlin's presentation, you will hear a testimonial for Andre Thornton, a successful entrepreneur and Cleveland Indians 2-time American League All-Star. Special thanks to our partners, Francis Mills, Director of Cleveland Office of Minority Health, and Aqeel Seals, Program Manager at Taussig Cancer Center. Aqeel will facilitate our open discussion later tonight in the program. Before we start the presentation, I'd just like to take a moment to share a couple housekeeping rules. The first portion of tonight's program will be recorded, and we will end the recording following Dr. Modlin's presentation. If you have any questions or comments throughout the session, please locate the chat box at the bottom of your screen. And again, thank you for joining us and supporting our Minority Health series. We know and we hope you'll leave the program this evening feeling empowered and inspired. Please welcome Dr. Charles Modlin.
Yeah, I hope everybody's doing really fine. It's a nice spring day. We finally made it through the winter, and everything's looking good moving forward. So I really appreciate the opportunity to be here this evening. I'd like to thank the Gathering Place and Francis Mills. I've had the opportunity to work with the Gathering Place for a number of years. They've always, the Gathering Place has always been a part of our annual Cleveland Clinic Minority Men's Health Fair. So I'm very appreciative, and I'm proud to be here. I've had the opportunity to present in person at the Gathering Place in the past, and hopefully we'll get to be able to go back to in-person meetings and gatherings sooner rather than later. Should I share my screen, or will somebody run the slides from your end? I can share my screen if that's easier. Yeah, let me go ahead and share my screen then. So can everybody see my screen?
Yes.
Okay, so let me get it into slideshow. So as indicated, I've dedicated the majority of my career to kidney transplantation. but also to minority health and elimination of healthcare disparities, with a major focus on minority men and African-American males who have the highest incidence of health disparities in a variety of areas of medicine compared to other groups. And what I want to talk about today, what our topic today is prostate cancer, but I'm going to touch on some other issues that are pertinent to maintaining, especially not only men's health, but also minority men's health. So one of the things I'm going to mix in is into the discussion is what we call BPH, benign prostatic hyperplasia, which can cause voiding symptoms in men. And one of the reasons I'm discussing that in the context of prostate cancer is men can actually have voiding symptoms, and voiding symptoms may be an early sign of prostate cancer. But I'm actually going to give you a take-home message, a very important take-home message to the men out there, and also the women, because what I found over the years is many women in many situations are making the healthcare decisions for the family and for the men. And we have to applaud the women out there, because a lot of times it's the women that are encouraging the men to go in and get preventative health screenings. So one take-home message that I want to pass along is that you don't have to have any symptoms, you don't have to have any signs at all to have prostate cancer. You may have urinary symptoms, but by and large, the majority of men with prostate cancer whom we diagnose in early stages actually have no symptoms whatsoever. So the take-home message is, men, if you're feeling fine, if you're avoiding fine, you don't have any pain or discomfort, that doesn't mean that you don't need to get screened for prostate cancer. So this is just the anatomy. A lot of people, a lot of men are not really certain, what the prostate is, where it's located. So the prostate is down in the pelvis. It sits on top of the rectum and below the bladder. And as you can see in the diagram, the urethra, the bladder empties urine right through the urethra, which goes right through the middle of the prostate. And so as you get older, if that prostate enlarges, you can see how it can put pressure on the urethra and make it more difficult for the man to empty their bladder. So as you can see in the diagram, the rectum is right here. And when we do prostate exams, we're inserting our index finger into the rectum and we're palpating the posterior surface of the prostate. 90% or 95% of prostate cancers actually occur in the peripheral zone. But most prostate cancers are detected before the urologist or the physician can actually feel anything. Most prostate cancers are now detected on what we call a PSA, a prostate-specific antigen blood test. So there are various causes of voiding dysfunction. I have more information on the slides than we're going to be able to have time to go through. But if you have bladder dysfunction, voiding difficulty, it's not necessarily just because of a prostate issue, an enlarged prostate, or a prostate cancer. Other conditions, stroke, diabetes, urinary tract infection, prostate infection, certain medications, anticholinergic, cold medicines, for example, can cause some bladder dysfunction, voiding dysfunction. So I talked about BPH, benign prostatic enlargement. We talked about how as you get older, it can swell, your prostate can swell, make it difficult for you to empty your bladder. And in some situations, in advanced cases, if your bladder is not emptying completely, that can lead to bladder stones. It can lead to backflow, or what we call hydronephrosis, blockage of the kidneys, kidney failure. So this is a condition that can be very serious. And that's why I say all men need a urologist in addition to a primary care. The correlate is most women have an OB/GYN who looks after issues that are specific to women's health issues. Urologists are surgeons and physicians, but we specialize in men's health issues. We also take care of women's urologic conditions also, but I always say every man needs a urologist. So some of the symptoms are urinary hesitancy. It takes a long time for you to empty your bladder. You may have to stand there for a while trying to, empty your bladder, slow stream, starting and stopping. We call that intermittency, weak urinary stream. A lot of times men may empty a little, then have to go back to the bathroom. And again, these symptoms may be indicative of prostate cancer, but not necessarily. So if you have any of these signs or symptoms, you need to see a urologist. I highly recommend that you see a urologist. Dribbling. You may think that you're done urinating and then you have some dribbling. So that just is an indication that you're not emptying your bladder all the way. Nocturia is where a lot of times men have to get up several times during the night. Again, that may be a symptom that you're not emptying your bladder all the way from an enlarged prostate. During the day, a lot of times men don't necessarily have frequency, but then when they become recumbent, they lie down at night. That fluid that's in your extremities actually gets reabsorbed into your blood system and then excreted by your kidneys, and so you have to urinate more at night. So again, straining to urinate, I talked about how this can lead to bladder stones, bladder infections, kidney infections. So again, every man needs a urologist. So there are things that we can do about treating and relieving men from a number of these symptoms. There are medications, usually are the first option. There are surgical options to treat these conditions. These are some of the common medications. You've probably seen many of these medications advertised on TV. I think the medication that is more commonly used is called tamsulosin Flomax. That's called an alpha blocker. What it does, it actually relaxes the muscles in and around your prostate so you can empty your bladder more effectively. And these other medications are very effective also. There's something called a 5-alpha reductase inhibitor, finasteride, Proscar, Avodart. Many of the men may actually be on these medications. And again, these medications may take a number of months to relieve symptoms, and only about 50% of the patients receive some kind of benefit from these medications. These medications interfere with the active formation of testosterone. So again, there's different types of minimally invasive office procedures. I think the gold standard is something we call a TURP, T-U-R-P, transurethral resection of the prostate. And I can go into more about this and answer questions more about this later if anybody is interested. There's prostate laser surgery, there's open surgery. And so getting into the issues, some other general men's health issues, men should be screened for prostate cancer. Black men actually represent a special group of individuals, and it's because African-American men, and I can get into more of this later, have a greater incidence and a higher mortality rate of prostate cancer, almost twice the incidence and twice the mortality rate from prostate cancer compared to white men. These are some of other conditions that I highly recommend when you go to your primary care doctor, your urologist. They can check you for any testicular masses, masses down in the scrotum. You should always be screened for high blood pressure, diabetes, and these other conditions. Kidney disease is something that we often don't talk about. Your primary care doctor should check a blood, it's called a serum creatinine, check your urine for any blood or protein in the urine. Again, it's important to get screened for colorectal cancer. Recommendations, usually you start at age 50, unless you have a strong family history, you start earlier. And now there's actually recommended screenings for lung cancer, depending on how many pack years smoking history you have. And one thing that we often overlook as physicians is the importance of screening individuals for mental health matters. So again, these are the recommendations, and the recommendations vary. American Cancer Society, American Urological Association. So the recommendations, these are from the American Cancer Society, men age 50. Let me see. Oh, does somebody want to Okay, is everything okay with the screen or? Okay, so yeah, age 50, they say they go according to what they consider to be your risk for prostate cancer. So if your average risk for prostate cancer, they recommend that you start screening for age 50. If you're high risk, age 45. And then if you have more than one first degree relative who's had prostate cancer, then you actually should start screening earlier. And screening, according to the American Cancer Association and American Urologic Association, is based on whether or not looking at your overall medical condition and your age, if it's believed, and the projections are that you have at least a 10 to 15 year life expectancy, then it's recommended that you undergo these screenings. There's different types of cancer. Most are what we call adenocarcinomas. And again, that's important to be aware of. These are the risk factors for prostate cancer. And I should say, the American Urologic Association recommends that men, white men, unless they have a strong family history, do not need to start screening for prostate cancer until the age of 55. And that screening consists of a PSA, that's a blood test, and a digital rectal examination. A lot of times men will come in and they will not want to get the digital rectal examination. I highly recommend that you at least get the blood test. The American Urologic Association recommends that African-American men of African descent should actually start screening for prostate cancer as early as 40 years of age. Again, due to the higher incidence, more aggressive cancer, higher mortality rate. These are risk factors for prostate cancer, your age. As you get older, you're at a greater risk for developing prostate cancer, your race and ethnicity. There are certain geographic hotspots that have been noted where there's a higher incidence of prostate cancer. The Southwest, your family history, of course, if you have a first degree relative, a father, a brother, an uncle. And then, it's been studied in some families that there's a genetic predisposition for prostate cancer. And the gray areas are some risk factors that we believe to be risk factors. Your diet, obesity, smoking, that's a risk factor for lung cancer, prostate cancer, colorectal cancer, heart disease. And we don't really necessarily know if prior history of prostate infection or STDs is a risk factor or not. More study actually needs to go into that. So again, inherited gene mutations, acquired gene mutations, environmental exposures. These are some of the things that we believe contribute to prostate cancer. Now, one of the big questions is, can prostate cancer be prevented? Well, there are no definitive studies that actually indicate that we can necessarily prevent prostate cancer, but we believe we can reduce risk factors. We need to do more studies. What we recommend a heart healthy diet. There have been studies that men taking selenium and vitamin D or vitamin E, there was something called the SELECT trial. The ultimate result of those trials did not show that selenium or vitamin D or vitamin E, reduce the incidence of prostate cancer. There are some studies that suggest that vitamin D actually may be beneficial in reducing the incidence of prostate cancer. So there are different stages of prostate cancer. The stage of your prostate cancer determines the way in which the urologist will address your prostate cancer. So I talked about screening for prostate cancer with a blood test. Probably 10, 20 years ago, we used to feel that the normal cutoff for normal PSA was 4 nanograms per mil. But now we've actually lowered that level, and it really kind of depends on your risk factor, your race. We feel that men with a PSA between 4 and 10, we call that, and actually the incidence where we find prostate cancer in men who have a PSA between 4 and 10, about 1 in 4 chance of 25% chance of the men having prostate cancer. If the PSA is above 10, then your risk of prostate cancer is over 50%. So in a man who's in their 40s, we generally now recommend, and again, these are just general guidelines. We recommend that your PSA should probably be between 2.5 or less, and if you're in your 50s, probably 3 or less. You know, in your 60s, around 3 or less also. So, and a lot of this also depends on what your PSA is doing over time. If it's rising, then that makes it the urologist more suspicious that you may indeed have prostate cancer. So a lot of times we can't make an interpretation on one reading. There are other things that prostate cancer that can actually elevate your PSA. As I mentioned, as you get older, your prostate enlarges, it makes more PSA. If you've had prostate infection, we see sometimes that individuals who are very active bicycle riders, their PSAs can be elevated. If you've had a recent cystoscopy or urologic procedure, that's going to elevate your PSA. Sometimes the testosterone supplementation can also elevate your PSA as well. Again, so that's why I say it's important to be under the care of a urologist. There are medications, I talked about the 5-alpha reductase inhibitors. If you're taking Proscar or Avodart for an enlarged prostate or urinary symptoms, it's important that your urologist, your primary care, be aware of this, because those medications can artificially lower your PSA, cut it in half of 50%. So if we get a PSA reading of 2 and you're on this 5-alpha reductase inhibitor medication, it's really 4. And again, that's a big difference. And so your urologist and primary care provider need to understand that you're on these medications, certain herbal mixtures, things that you may get off of the internet. We don't know what type of substances are in these medications. So tell your physician if you're taking any supplements also, so they're aware. So in addition to doing a PSA, oftentimes we'll look at the percent free PSA. The percent free PSA is the amount that is not complex to protein in your bloodstream. It circulates freely. And generally, we feel that if your free PSA is 21 or higher, that there's a lower incidence that you would have prostate cancer. If it is lower than 21, then we feel that that may actually need to be evaluated, because then you have a higher incidence of developing prostate cancer. There are some other tests that have been studied, something called 4K. Again, you know, when you go to the urologist, they may run some of these additional screening tests to really determine what that PSA or what that elevated PSA level means for you. So I talked about the digital rectal examination. Genetic testing is indicated for some men with prostate cancer. Now, the diagnosis for prostate cancer, you cannot diagnose prostate cancer just by doing a rectal exam. You cannot diagnose prostate cancer just by doing a blood test. The only way, or an MRI or a CT scan, the only definitive way to diagnose prostate cancer is to do a biopsy. And then if we diagnose prostate cancer, then we stage the prostate cancer to determine whether it's localized or whether it's gone beyond the confines of the prostate gland. We'll often do a CT scan, bone scan, and again, these are staging imaging modalities that actually help us determine the stage of your prostate cancer. So in order to do a prostate biopsy, we traditionally use what we call a transrectal ultrasound. It takes about 5 minutes to do a prostate biopsy as an outpatient procedure. We numb up the prostate, give you antibiotics at the time of the prostate biopsy. There's something that's been around maybe for a few years now where we utilize images from a MRI. It's called an MRI fusion biopsy. That helps us be more specific in terms of where we target our biopsies. Generally, we do not do an MRI fusion prostate biopsy until we've already done a standard transrectal ultrasound biopsy where we get negative results, but we still think there there may be a higher incidence of prostate cancer. So that's MRI fusion is not generally the first methodology whereby we perform biopsies of the prostate. So then we get into we look at the biopsy, and then there's different what we call Gleason. There's a Gleason scoring system, and basically what that is, the pathologist looks at the characteristics of the prostate biopsy under the microscope, and there are different patterns whereby they can determine whether a specific prostate cancer, how aggressive it may actually behave. The scoring system generally goes from 6 to 10. The higher you go on that scale, the more aggressive the prostate cancer can be. So, and then there's different ways to treat prostate cancer based on the individual patient, their comorbidities, their age, what projected life expectancies, the Gleason score for the prostate cancer, their PSA level, findings on the imaging studies, the CT scan, the bone scan. So we assimilate all of this information, and then we determine what the best therapy is for a given individual. So this is, the different Gleason grade groups. And again, your urologist can go into more detail and explain this. So again, the staging system, localized, regional, distant. Localized, there's no evidence of the cancer spread outside of the prostate. The way in which prostate cancer spreads is generally it can go to the bones and the lymph nodes, and that's why we do CT scans and bone scans. A lot of times, if your PSA is under 10, research has shown that we don't always have to do these imaging modalities because there's a lower likelihood that it would be spread. And again, survival. A lot of studies have been done. If you have prostate cancer that is localized, you have nearly 100% 5-year survival. Even if it's regional, there are things that can be done about that. If it's metastatic, then your 5-year survival actually goes down. So there are different ways to treat prostate cancer. So basically the general ways in which we treat prostate cancer, again, I talked about how we have to assimilate a lot of the information. We have a comprehensive conversation with the patient. A lot of times patients, and it's good if they have family members available to support them and ask questions. Of course, we welcome that. Better informed patient can make a better decision. If you look at, so there's surgery, which is complete removal of the prostate, and there's different ways to do that. Open surgery, robotic surgery, laparoscopic. There's radiation therapy for prostate cancer. Those are the two major ways. But we found out over the past several years is that if you have a low-grade Gleason 6 or Gleason 7 prostate cancer, again, confirmed on a biopsy by the pathologist, and if you have a PSA under 10, oftentimes we can do what we call active surveillance or observation. That's where we don't immediately feel that it is necessary to perform surgery or radiation. We can observe it, and what we're doing, we're repeating your PSA, your blood test every 3 or 4 months for several years to make sure that PSA is staying relatively the same level. And if we would see that it is rising, then we would oftentimes repeat a prostate biopsy every year or two for men on surveillance to see if there's any change in that Gleason score or characteristics of that prostate cancer. I'm not going to go into all these other therapies, but the bottom line is surgery compared to radiation, both the short and long term of survival is essentially the same. But then there are specific decision. We inform individuals about the risk and benefits of radiation versus surgery, the potential side effects of both modalities to help the patient make the best decision that is best for them. So I'm actually going to, that was just kind of a general overview. I can go into more detail about the risk of surgery, the risk of radiation therapy. I mean, just generally, I mean, if a man has surgery to remove the prostate, we have to make sure that they are a surgical, good surgical risk. It depends on their body habitus also in many situations. Anytime anybody is going to go through surgery, laparoscopic, robotic, open, we have to inform them that there's a risk that they may lose blood, they may require blood transfusions. Erectile dysfunction can occur, stress urinary incontinence, leakage can occur. Actually, it occurs in everybody after surgery for prostate surgery, but it usually resolves over a period of time. There are a minor percentage of individuals who need additional therapy to treat that. Now with radiation therapy also, men can develop erectile dysfunction. They can develop stress incontinence, and then they can have other radiation-induced complications to the bowel, the bladder, the rectum, things like this. And again, we discuss all of these potential risks and benefits in detail with patients so they can make the best informed decisions that they can. Yeah, I'm going to go ahead and stop here. And then I know Aqeel actually, Aqeel Sills, one of my partners, actually wants an opportunity to speak as well, and I can take any questions as well. But I just wanted to give you a general overview of what is prostate cancer and why it is important that men get screened for prostate cancer, whether or not they have any signs or symptoms. I highlighted the fact that African-American men have a greater incidence and a greater mortality from prostate cancer. And again, the American Cancer Society, American Urologic Association recommends that men of color, Black men, actually, because of the higher incidence and death rate, should start screening for prostate cancer at the age of 40. And again, the screening modalities are digital rectal examination and a PSA blood test. There are some other specific screening options that the urologist may want to utilize, but a lot of these are individualized according to the patient. And again, I highly recommend that every man should actually see a urologist. I think it's also important that we start educating even our young men, teenagers, about what is prostate cancer. I think men need to start talking to these young boys and young men so that they will understand when they reach a certain age what is expected of them to maintain their health, that they need to undergo prostate cancer screening. And the main take-home message is that you don't have to have any signs or symptoms at all to have prostate cancer. And if we can diagnose prostate cancer early, before it spreads, while it's still localized, we can affect almost 100% cure. So thank you for this opportunity. And again, happy to be here. I can take any questions as well.
All right. Thank you so much, Dr. Modlin. That was just a great wealth of information. I know for me and others who work in the medical field, we are more kind of in tune to a lot of, or privy to what you were discussing. But we really kind of looking at the topic of tonight, really want to delve into, you've made it very clear that African-American men share the highest risk, incidence rates and mortality. Is there any determined reason why African-American men are at that significant of a higher risk of incidence and mortality?
Actually, that's a great question. There have been a number of studies that have postulated that and questioned, why that is. But there's been research even at Cleveland Clinic that actually recognizes there is a hereditary prostate cancer gene. We do know that genetics, biologic predisposition actually accounts for the greater incidence of prostate cancer. Now, whether or not a man will exhibit or whether or not that gene will become active may be determined by environmental exposures, whether the man actually is smoking, how much is he smoking, whether he's drinking, whether he's consuming a high fatty diet. There's something called the two-hit hypothesis theory, where not just because of prostate, not just related to prostate cancer, but an individual may inherit a gene for hypertension, heart disease, and then if you combine that hereditary predisposition with certain behaviors or environmental toxic exposures, that actually may activate that gene and express that gene. So, and we've seen this in diabetes also. So that's why it's very important that we as men talk to our younger men and boys and let them know what cancers and conditions are more prone or prevalent in our family history. And oftentimes in the Black community, for whatever reason, maybe I think it's been taboo in the past, that we were afraid to talk about, diseases or medical conditions that run in our families. We keep it in the closet a lot of times. So,
Absolutely.
But yeah, that's a great question. More research needs to be done. But let's talk to each other, during family reunions or just on a regular basis.
Absolutely. Thank you. And now it's kind of flows right into the next question. But as we talk about normalizing the conversation, and obviously, there's a huge gap in, obviously men who actually have primary care physicians and follow through with their PSA screenings or other preventative testing. Is in your experience as a urologist in the medical profession, seeing tons of patients, tons of history with Minority Men's Health Clinic, do you see a disconnection between like culturally appropriate communication between patient and the caregiver or patient and the healthcare provider? Does that kind of also foster that non-participation in African-American men?
Yeah, you're referring to the importance that healthcare providers also be culturally competent, culturally sensitive, and understand a lot of the history that Black men have faced, when encountering the medical professionals and researchers. We've all heard of the infamous Tuskegee syphilis experiment, where I think it was about 850 Black men. This is back in the 30s and 40s. This study actually, unfortunately, continued up until 1972, but it was a study whereby the Department of Health and Human Services of the U.S. government deliberately denied treatment for about 850 men who had syphilis, so they could determine what the natural consequences of untreated syphilis would be. And that got out into the community. It's led to a lot of distrust that many people of color have towards not only researchers, but doctors. And I think if healthcare providers would demonstrate to this population specifically that we understand, why there is a lot of distrust. But quite honestly, I think most healthcare providers, the overwhelming majority of healthcare providers go into this profession for the right reasons, or are there to serve individuals, or are caring and compassionate. And so I think it was Booker T. Washington who said, we must not let our grievances of the past interfere with our opportunities of today. And so, there's more transparency in medicine. We're trying to get out and educate people and try to improve their health literacy so people will understand how this is beneficial to them to get screened for prostate cancer and some of these other conditions. So I think this is a new day. One thing that actually the COVID-19 pandemic has done, it's unmasked to the rest of the world, essentially, the existence of healthcare disparities, because African Americans have been found to have a higher incidence of COVID and hospitalizations and death rates. And that is, we know it's because there's a higher incidence of health disparities, chronic disease, social determinants of health. And so this is an opportunity for us to raise awareness and educate the community about how they can better improve and how we can better improve our own health status and that of our families. So, but it is very important that healthcare providers become more culturally sensitive, more culturally competent, and empathetic, and let it be known that they understand where people are coming from.
Thank you. And right before we go into our next set of questions, Dr. Mon, I want to ask if you would grant administrative access back to the gathering place so
Okay.
they can allow those in the waiting room access to the meeting.
Okay. It's easier to do surgery than operate these.
And Simone, if you can confirm once you have access.
All set, thank you.
All right, thank you. We do have quite a few questions from members in the chat, but as you kind of talked about research a little bit, I know this is more of a sore topic in minority communities, obviously based off of kind of the historical context. Do you think African American men or other minorities could greatly benefit from participating in clinical trials, and if so, how?
Oh, very much so. And there's been research in a variety of studies, especially looking at pharmaceutical companies that have actually developed medications to treat cancer. And what they've shown is in those clinical trials, they typically only get about 5% of the participants who are African American in those clinical trials. And we do know there are certain instances where individuals from different races, and again, I recognize that there is no real definition of what race is, but individuals from different racial or ethnic backgrounds actually, in some instances, for example, in antihypertensive medication treatment, in immunosuppressive treatment that we use to prevent rejection following transplantation, there are different, there's a different response to certain classifications of medications. And the majority of pharmaceutical medications out on the market have been developed and tested utilizing 95% of the individuals, or 90% are white males. And for one example, there's a enzyme in the liver, it's called P450. And we do know that African Americans have different levels of this enzyme in the liver, which is utilized to metabolize some medications that are given. So it's very important that we try to encourage more African Americans and people of color, Asian Americans, Hispanic, Latino Americans, to participate in these clinical trials so that we can develop more medications that are going to be more efficacious. There's an example I've mentioned before. The first medication approved by the FDA to be utilized by one group of individuals, one race, self-identified African Americans, was used to treat congestive heart failure. It's a medication called Bidil, B-I-D-I-L. They had enough African Americans in the study to demonstrate lower hospitalization rates and a 45% reduction in death rate when African Americans were taking this medication to treat congestive heart failure, in addition to standard therapy. So who knows what types of medications and innovations can be discovered if we get more individuals to participate. One good bit of news that we've seen recently in the development of the Pfizer and Moderna COVID-19 vaccines, there were roughly around 30% of minorities in those studies, about 10%, 9 or 10% of which were African Americans. So that's much higher than what is typically seen. So yeah, that's a very important thing that we need to focus on, is trying to encourage more participation in clinical research trials. And I can assure you, as you know, Aqeel, working in the Cancer Center, there's a lot more transparency in clinical research now. There are minorities, scientists and researchers, and people, consenting individuals. There's something called community-based participatory research, where individuals from minority communities can actually help design a lot of these research trials. So in contrast to what happened in the past, there's a lot more transparency. There are a lot more checks and IRB approvals, and so what happened in the past, there's no way in that can actually happen again the way that happened.
Thanks again. I really wish, more people could actually hear that particular statement, because I definitely think there's, definitely a whole nother level of assurances, regulatory guidelines to go along with the research current day. But in that same regard, do you think, or are Hispanic men kind of at a similar risk of incidence of mortality as African-American men? And if so, at what age should Hispanic men be screened for prostate cancer?
So in general, I mean, the studies have shown that they don't have as high of a risk of prostate cancer compared to African-American males. So the recommendations from the American Urologic Association, basically you want to look at family history. And again, you want to look at a lot of the risk factors that I talked about. But as far as the early screening at age 40, that's pretty much a recommendation for African-American males. Asian American males, we have not seen that higher incidence of prostate cancer either. So, but again, like I said, I still go back to the fact that I strongly believe that every man should have a urologist. We can augment the care provided by primary care physicians. So in addition to a primary care provider, I think every man should actually have a urologist, just like most women have a OBGYN to help take care of their health concerns.
Thanks. A question from the chat. It says, given that prostate cancer is more aggressive in the African-American community, should length of time between visits be shorter with active surveillance? So I'm assuming she means, should those visits be shorter? Or even to also ask a separate question, should PSA screenings occur more than once a year?
Right. So, those are a lot of those. The answer to the question is it really needs to be individualized. And again, it depends on what your starting PSA is. When that prostate cancer was diagnosed, it really depends on your Gleason score. Again, which is an indication of how aggressive that prostate cancer can be. And then there are certain patterns that the pathologist can look at. If you have what they call a cribiform pattern, there's different patterns under the microscope in which the glands may be growing or configured that need to be taken into consideration. It depends also on serial PSAs, how quickly, or if that PSA is going up, how rapidly. So there's no just set answer necessarily. All those things have to be individualized in terms of how often you should get a PSA. And again, actually, there was a study by Dr. Andrew Stevenson when he was at Cleveland Clinic that showed actually African-American men on surveillance who have Gleason 7 prostate cancer. And so generally, we only do surveillance for men who have a Gleason 6 or 7. If you have like an 8, 9, or 10 in the more aggressive cancers, we would not recommend surveillance whatsoever. But he observed in his study that African-American men with Gleason 7 have a higher progression rate. And again, there are other studies. There's something called a prostate oncotype testing that takes into account your PSA, the characteristics of your prostate cancer. It looks at the volume of your prostate cancer, and it actually can give you a predictive variable in terms of what the percentage or the chance that you as a given individual may have aggressive prostate cancer. But again, all these things have to be individualized between the patient and the urologist.
Another great point. One of the things that I often hear in the community when interacting with men is, I have a normal PSA. Yeah. And they'll, they kind of overgeneralize that. For most men, they'll say, well, if his is a 2.5 and it's normal, then a 2.5 for me is normal. Right. And, you kind of hit on that with, every man is going to have its own individualized normal PSA level. So that's, again, it's definitely important that we drive that awareness so that way men are aware and know that they, need to know what their number is. And that,
I think it's also important that we educate, to get back to one of your former questions, I think it's important that we educate, and I think most primary care physicians and family physicians are aware of this, but not necessarily, that there are different screening recommendations where, Black men, it's recommended to start at age 40 versus white men 55. If you're a white male and you have a strong family history, then you too need to start at an earlier age. I've encountered some patients who were told that, some Black men who were told that they don't need to start until they're age 55. Well, I mean, that is not really one of the current recommendations. So we not only need to educate the men out in the community, we also need to educate primary care providers. Again, that's why I say we as urologists, we are here to help the primary care providers. They're busy trying to manage every other, facet of the individual's health. And so we're just here to help. So yeah, very, very important.
How much weight does genetic predisposition carry? And if there is cancer in the family, will the person always get that actual cancer or another related cancer?
Yeah, well, there's no way. I haven't seen any studies that actually define the exact probability that a given individual will have prostate cancer, necessarily because their father or uncle or brother had prostate cancer. But we do know that if you have a first-degree relative, your likelihood for yourself to develop prostate cancer does go up. Again, that underscores why the recommendations to start screening as early, 15 years earlier, if you're a Black male, especially with a strong family history of prostate cancer. And again, just because you have a strong family history, that does not necessarily mean that you yourself are going to develop prostate cancer. I think it just means that you need to be more alert, more aware, and more willing to get screened yourself and have a better understanding of why it's important to get screened. And I've encountered, as you have also, a number of men who insist that they don't have any signs or symptoms, and so they're not going to get screened. And the other thing you alluded to is that, and this is not just men of color, but men in general fear that prostate exam. And one thing that we have told men, come in, at least get the blood test. We're not going to tie you down and force you to have that prostate exam. The thing is that if you wait to have prostate cancer detected on a prostate exam, where we feel what we call a nodule, if that's the case, 50% of men who have nodules have advanced prostate cancer. Not every nodule is prostate cancer, but if you can detect and palpate prostate cancer, you have a 50% chance that it's already outside the prostate. Most prostates, we call it T1C. It's terminology where it's a PSA detected, the blood detected prostate cancer rather than being detected on examination. So most prostate cancers are detected by that PSA blood test.
And as we kind of discussed that modality of PSAs and DREs, more recently, there's been a new ISO PSA. Can you talk about how prevalent that is now as being an offered modality of screening, and how different is it from your general PSA?
Yeah, so ISO PSA actually was developed by a multi-center trial, but investigators at Cleveland Clinic. And so ISO PSA is a different form of PSA. And the indication to get an ISO PSA is if your total PSA is 4 or above. And then what we would do, it's a blood test. And if your ISO PSA comes back 6.1 or higher, it is suggested that, and again, it's not diagnostic of prostate cancer. There's no blood test itself that is diagnosed or diagnostic of prostate cancer. But if your ISO PSA is 6.1 or higher versus lower than 6.1, if it's higher, it suggests that if you have a prostate biopsy, then it is more likely that the urologist will diagnose or find prostate cancer. If that ISO-PSA is less than 6.1, it suggests that if you have a biopsy, then it's less likely that you will be found to have a prostate cancer. Because remember, PSA is not specific for prostate cancer. Again, if you have an enlarged prostate infection, that can be the source of your elevated PSA. So that is a tool. The ISO-PSA is a tool for many men and their urologists to determine whether or not they should have a prostate biopsy to begin with. You know, it's been around maybe for a year or so, maybe a little bit more than a year, and it's still a tool that is available. The first year, it was actually part of a clinical research trial, and so there was no cost to the men. But now, if you want to get that PSA, you need to discuss that ISO-PSA. You need to discuss that with your urologist before they order it, because there is a fee associated with ordering and having that test drawn. But it's just another tool that in the armamentarium of the urologist that we can use to help determine if a man should have a prostate biopsy. Because remember, even though the risk and complications of a prostate biopsy are minimal, you know, still there can be some minor discomfort. There can be some bleeding. There can be some infection, you know, when performing a prostate biopsy. And again, also, again, it's just another tool overall, but the only way to diagnose prostate cancer is actually doing a prostate biopsy.
Thank you. Thank you. And we're still going to address a few more questions. Sorry, my office light keeps going out. We're going to address a few more questions from the chat while we give Andrew time to join. He's going to share his story with us. One of the questions says, at the beginning of your presentation, you stated that all men should have a primary care and a urologist. Is a urologist recommended for all men or just men with a family history of urological issues or other cancers?
I actually recommend that all men should have a urologist, and I say that for a variety of reasons, because, and again, there are some complexities involved, and you know, it's becoming more and more complex all the time with the advent of new PSA screening modalities, the ISO-PSA, and a lot of the information that urologists are specifically trained to interpret. And I think urologists are the ones best suited to actually help the patient interpret and understand what a lot of this testing means. But in addition, you know, urologists, we specialize not only in the treatment of prostate cancer, but benign prostate disease, bladder cancer, kidney cancer. There are a number of things that we're looking for, testicular cancer. And we do these full comprehensive evaluations and examinations on a routine basis. So, you know, even, and I think it's important, you know, when you go to the primary care doctor's office, the urologist, you know, the dermatologist, wherever you go, I think it's important to actually ask to get your blood pressure checked also. Because again, hypertension is what we call a silent killer. It can lead to heart disease, you know, kidney disease. The other thing is that we've seen in the literature, there are a number of men, even young men, that are experiencing what we call erectile dysfunction, impotency. It's not something that men want to talk about all the time, but one of the important facets or areas of research have demonstrated that oftentimes men who are experiencing ED, erectile dysfunction, that can actually be a precursor 3 years earlier than them being diagnosed for coronary artery disease. So if a man comes into a primary care physician or urologist office complaining of erectile dysfunction, that can be a tip-off that they may have underlying early stage heart disease that should be evaluated. So see, urologists are aware of a lot of these things. And again, it's our job to follow up on this and you know, do overall comprehensive evaluation. So I recommend that all men see a urologist, not only men with an elevated PSA.
Thank you. And we'll ask one last question before we move on. And if there's other questions in the chat, please continue to send them. We'll make sure that they get answered. And kind of as you alluded to, younger males in general, if testosterone fuels prostate cancer and not estrogen, how come young men whose testosterone is at its highest don't have higher incidences of cancer?
Yeah, I've never actually thought about it in that perspective. You know, I mean, you know, testosterone is the male, you know, hormone that helps stimulate muscle mass and you know, again, there's enzymes that converts testosterone to the active form dihydrotestosterone. You know, that men need for sexual health and sexual function as well. You know, as we get older, there can be morphological changes, you know, genetic, biologic changes in the prostate itself that may make higher levels of testosterone more deleterious to helping potentiate, you know, development of prostate cancer. I would actually have to look more into that question. I've never really thought about it in that perspective. So that's something I don't necessarily have an answer to. But there actually have been studies that even older men who are suffering from, they call it hypogonadism, low testosterone levels, where initially we thought that we cannot give older men testosterone because then that would actually predispose to them developing prostate cancer. We do feel that we can safely give men testosterone supplementation if they have low testosterone levels, but we have to be careful in monitoring their testosterone levels and their PSA and screening them for prostate cancer. So just being older is not a contraindication to giving somebody testosterone supplements if they have hypogonado or erectile dysfunction, or if their testosterone levels are low. So, you know, having normal testosterone levels at a younger age also helps, you know, with your growth, your development, your sexual health, your bone health, and you know, other things. So, and again, it's important that men going to the urologist, the primary care physician, if you have erectile dysfunction, don't be embarrassed. I mean, go ahead and discuss it with your physician. You know, they can check your testosterone level, your PSA, and you know, do a comprehensive assessment.
Yeah, thank you. Well, Dr. Modlin, it's always a pleasure. I definitely want to thank you for the wealth of knowledge shared. I definitely wish we had a million more men who can sit under that information sharing. And we, you know, regardless whether, you know, prostate cancer is slow growing or less aggressive or not, you know, cancer is always, you know, kind of one of those sore spots that we don't really want to hear about. But thanks to the Gathering Place, you know, there's a place for support. There's a place for refuge. And I want to bring kind of light to one of their support programs, which is Prostate Partners. Sandy, if you have a minute, would you be able to tell us a little bit about what Prostate Partners is? You know, what days is the program facilitated and what can men expect?
Sure, thank you very much. I appreciate that. And again, thank you, Dr. Modlin. It was all very, information is the best, is the king. The more you know, the better prepared you are. Very briefly, I'll just tell you my journey with prostate cancer. I'm a 6-year survivor, was diagnosed because of my PSA testing, and I got caught with the rising PSA, did a biopsy, had a Gleason of 8, went through surgery, radiation, and hormone therapy. And after that was doing well, then dealing with some reoccurrence. So I'm now on a course of Casodex that's been maintaining it. So I'm living proof that I can beat that 5-year number that you had, Dr. Modlin. I'm now on my 6th year and doing well. Just a real quick, tell you a little bit about the Gathering Place. There are, among the other programs the Gathering Place has, is a program that was extremely helpful for me called the Prostate Partner Group. The Prostate Partner meets both on the east side and the west side. We meet on the second Thursday of the month on east and on the third Tuesday on the west. The programs are pretty much a mirror image of each other, but basically our programming is that we have a speaker like Dr. Modlin or other doctors, pathologists, radiologists. We have some social workers that do talk. We have cooking demonstrations and cookouts on healthy grilling, all the different subjects that are important for the continued knowledge of a prostate cancer survivorship so that you know what you need to know going forward. And it gives you a chance to meet with other men that are going through the same journey as you are. And that group is really for prostate partners, for survivors and their partners as well. So we definitely encourage you to come and learn from that. That's where I first got exposed to the Gathering Place, and that program was extremely helpful for me, learning how to navigate my survivorship. We also have another program that starts before that one. It's a prostate cancer information session, and that one is just for men. It's one that myself, staff member from Gathering Place, and my partner on the west side run that program. And it's an opportunity for men newly diagnosed to come to talk to other men that have gone through the prostate journey and answer the questions that your doctor, your nurse can't answer. We don't give medical advice, but we give that other information about quite often a lot of the questions that you have. I think, as Dr. Modlin kind of touched on, the good news about prostate cancer is there's lots of different choices, lots of protocols, so there are no right or wrong answers. The bad news is there's lots of choices, lots of different ways to go. So it becomes a very confusing path, and that's why you do need a good medical team around you to take in their advice and then match it up with your quality of life interests. And I'll be glad to answer other questions for you, Aqeel. And I should show my favorite. Aqeel knows this one, doctor, but I do have this one right here. If you see the, don't fear the finger.
It's not the most inviting thing we use out in the community, but it starts a fun conversation.
Sure.
But one more thing, Sandy, right now with the impacts of COVID, is Prostate Partners fully virtual, or are there still in-person meetings?
Right now, we do, because of COVID, we are doing the virtual meetings. And that goes for both of those programs, the early one, information session, and the prostate partner ones. Both of those are virtuals. And if anyone has any questions, that also I do, and another gentleman on the west side does do, is that we do some one-on-one mentoring. So if someone has some questions, they can contact the Gathering Place, and they will put them in touch with one of us that's more covers the east or west. And I've done a lot of times, a lot of one-on-one counseling, if you will, with men newly diagnosed to kind of help them talk it through. And it's a lot of confusing information that's getting hit with all at once.
Absolutely. Well, thanks again, Sandy. I really appreciate all your insight and information about the upcoming program.
Can I put another plug in, Aqeel?
Absolutely, go ahead.
Another plug for the Gathering Place. An important part of the survivorship is exercise. And the Gathering Place does have a wonderful exercise program, both east and west, that they're doing virtual now. But it's a very good exercise program that does help you, hits the main points that you do need on your keep you in fit, both cardio and exercise and balance. And quite honestly, it's a great way also to network with other people going through the same thing as you. So that's my other commercial I'll put in for Gathering Place.
All right. Thanks again, Sandy. Again, the Gathering Place is just a wealth of resources and support, along with the Taussig Cancer Center. If there are any men or family members who are looking to be screened, our patient navigation program does an excellent job with connecting patients to those services. And also another resource is the Minority Men's Health Clinic, which Dr. Modlin oversees. Men can also visit, that clinic and make sure that their preventative measures and screenings are taken care of as well. And I believe all of those resources will either make their way into the chat or be shared via email. So again, at this time, I'd like to thank everybody for joining, and I'll pass it over to Beth.
Yeah, thank you so much. And I just want to say thank you, Sandy, for taking the time to answer some questions. One other thing we do offer, if somebody doesn't have access to virtual platform or Wi-Fi, we do, you are able to attend our programs on the phone as well. It's dial in. So just to keep that in mind. And just to let all of you know on the call tonight, if you or someone you know is coping with cancer and would like to get support or have more information, please call us at the Gathering Place, either by phone at 216-595-9546, or you can visit our website at touchedbycancer.org. We also hope that you will take the opportunity to attend the rest of our minority health programs in this series. You can register for those additional programs by using I think, is there a QR code on the screen? Are we doing that? Nope. Okay, sorry about that. You can call, you can just go online at the Gathering Place on our calendar and register, or you can call that same number, that 216-595-9546. Please call and we'd be happy to get you connected for the rest of the programs in this series. But a real special thank you, Dr. Modlin. Thank you so much for taking the time to share your time and expertise. And then again, thank you, Sandy, for giving some information on the Gathering Place. And Aqeel, very big thank you for moderating the questions. And we really appreciate this partnership with the Cleveland Center for Minority Health, as well as the Cleveland Clinic Taussig Cancer Center. Tonight would not have been possible without our partners. So we thank you, and please take care and have a good evening.